Hi, my name is Tammy Valenta. I'm a nurse practitioner in Oakland, California, working predominantly with the transfemale community. The tutorial today will cover basics about the transgender population, specifically trans women. I'm going to include definitions, prevalence of the population, barriers to health care, hormones and other treatments and risks included with those, issues of adherence to prescribed treatment, and how as practitioners we can improve health outcomes. To begin, how do we express gender? We manifest characteristics of our personality, appearance, and behavior that are culturally defined as masculine and feminine. Gender nonconformity, though, is the extent to which a person's gender identity, role, or expression differs from the cultural norms prescribed for people of a particular gender. Because of the influence of prevailing social norms, that can cause clinicians to harbor negative stereotypes and feelings about transgenders. This population has repeatedly suffered from ignorant clinicians' mistreatment and pathologization of their conditions. Transgender is an umbrella term used to describe people who have gender identities, behaviors, or expressions of gender that are not traditionally associated with their birth gender. Opinions on the term vary by geographics and by individual. Transgender encompasses a wide variation of gender identity, including bigender, genderqueer, intersex, gender nonconforming, and transsexual. Transsexualism is considered the most extreme condition of transgenderism, wherein a person seeks hormonal and/or surgical treatment to externally express their internal gender identity. Gender dysphoria is defined by the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, called the DSM-5, as the discomfort or distress caused by the incongruency of the individual's cisgender and their gender identity, which interferes with social, school, and other areas of function. It should be noted that there's no causal connection between gender identity and sexual orientation. So transgender people may identify as heterosexual, homosexual, bisexual, or celibate. Now entering barriers of care. Optimal health for the transgender person is dependent on the level of knowledge and competency of their practitioner, as well as removal of structural barriers that prevent access to care and limit service. Transgender and gender nonconforming people frequently experience discrimination when accessing health care, from disrespect and harassment to violence and denial of services. In the National Transgender Discrimination Survey in 2010, respondents showed 19% were refused medical care, 50% had to teach their providers about transgender care, and 28% postponed medical care due to discrimination. Insensitivity of healthcare professionals has been cited as a reason that services such as HIV/AIDS education and testing are not accessed. Behaviors or examples in ways that we show disrespect of the individual's expressed gender are referring to a trans woman as he or him, not acknowledging the person's preferred name. For example, calling for a trans woman in a busy healthcare setting by using their legal name. For example, the person's preferred name is Amanda, legal name is Christopher. The person is showing outward signs of being feminine, but is being called Christopher in that setting. Also, requesting information about genitalia when the reason for seeking care has nothing to do with that. For example, coming in with a sore throat and being asked about genitalia. Also, access to female or male restrooms only and not having a neutral ground to use the restroom. That requires the individual to make a choice publicly that they may not be willing to make yet. Treatment is very individual, and the following includes a brief discussion about possible treatment options for trans women and potential risks. Transition for trans women is the process of feminization through body modification surgery or hormone therapy. The World Professional Association for Transgender Health, WPATH, is an international multi-professional organization that has published standards of care for gender nonconforming people. The seventh version of these standards, SOC 7, was published in 2011 and is considered the gold standard for treatment of gender dysphoria. Within those standards, it states that hormonal and/or surgical treatments may be medically necessary to alleviate gender dysphoria. Some transgender people opt for no surgical alterations, while others will have sexual reassignment surgery or breast augmentation or reduction. The degree of transition is individual and a multifaceted decision, and the decision for treatment is often based on religious, cultural, or family considerations, as well as financial and health status. The most commonly studied hormone regimen is estrogen with anti-estrogens or anti-androgens. Anti-androgens such as spironolactone suppress testosterone, minimizing the need for estrogen and subsequently reducing risks associated with high-dose estrogen use. Some transgender people opt for no surgical alterations, while others have sexual reassignment surgery, breast augmentation, or reduction. The degree of transition is individual. It's multifaceted decision, and the decision for treatment is often based on religious, cultural, or family considerations, as well as financial and health status. The most commonly studied hormone regimen is estrogen with anti-androgens. Anti-androgens such as spironolactone suppress testosterone, which minimizes the need for estrogen and subsequently reduces risk associated with higher doses of estrogen. Practitioners are cautioned that the risk of hormone therapy increases with higher doses, especially doses exceeding supraphysiological levels. Health risks related to feminization hormones include hypercoagulability, leading to deep vein thrombosis and pulmonary embolism, depression, mood swings, prolactinemia, elevated liver enzymes, migraine headaches, and decreased insulin sensitivity. The risk of this hormone Studies in New York, San Francisco, and Ontario, Canada have reported widespread use of non-prescribed hormones. The reasons given were lack of health care, cost, distrust of healthcare systems, and the belief that more is better. Patients have been known to buy non-prescribed drugs from Canada and Mexico, and many of my clients have reported buying birth control pills from friends to begin their transition. Another common practice are hormone parties, where they share their hormones and inject each other. Often, these people don't know what hormones they're getting or what the dosage is. So the health repercussions can be devastating. Healthcare utilization, barriers to care, and hormonal use were addressed in a small New York City study by interviewing trans women. Although the majority of participants reported having health care and seeing a provider in the past year, this did not result in adherence to provider recommendations for hormone use. In that study, 32% of participants found that lack of knowledgeable caregivers was their primary barrier. So this gets back to lack of competency in healthcare. In a similar study in Ontario, Canada, similar results were found that even when trans women had full medical coverage and were seeing a provider, they were using non-prescribed hormones. There were an estimated 43% of participants in the study that were taking hormones. 25% of those were taking hormones from 1 to 3 non-medical sources. They found that the reason for this usage was due to lack of transition-related services. This is interesting because it's similar to studies of the general population, which have reported that 30% of the general population do not follow prescribed directions when taking medications. Purposeful efforts need to be instituted toward creating a receptive environment to counter the barriers to care and to improve their outcomes.